Hi, today we will go talk about autoimmune disorders. The basic principle of this disease is characterized by immune-mediated damage of cell tissue. US prevalence is 1 or 2% involved, loss of cell tolerance, self-reactive lymphocytes are regularly generated but develop central thymus and bone marrow or peripheral tolerance. Central tolerance in thymus leads to T-cell thymocytes apoptosis or generation of regulatory T-cell. Air mutation result in autoimmune polyendocrine syndrome. Central tolerance in bone marrow leads to receptor editing or B-cell apoptosis. Peripheral tolerance leads to energy or apoptosis of T and B cell. Fast apoptosis pathway mutation result in autoimmune lymphoproliferative syndrome. Regulatory T cells suppress autoimmunity by blocking T cell activation, producing anti-inflammatory cytokines, interleukin-10 and tissue growth factor beta. CD25 polymorphism are associated with autoimmunity, uh, multiple sclerosis, and type 1 diabetes mellitus. FOXP3 mutation lead to IPAX syndrome, immune dysregulation, polyendocrineopathy, enteropathy, and X-linked. More common in women, classically affects women of childbearing age. Estrogen may reduce apoptosis of self-reactive B cells. Etiology is likely an environment trigger, genetically susceptible individuals, increased incidence in twins. Association with certain HLA types, HLA-B27 and PTP-N22 polymorphism. Environmental triggers lead to bystander activation or molecular mimicry. Autoimmune disorders are clinically progressive with relapse and remission, and often show overlapping feature, particularly explained by epitope spreading. Systemic lupus erythematosus, chronic systemic autoimmune disease, place and remission are common. Classically arise in middle-aged females, especially African American and Hispanic women. May also arise in children and older adults. Less dramatic gender bias, antigen-antibody complex damage multiply tissue is type 3 hypersensitivity reaction. Poorly cleared apoptotic debris from ultraviolet damage activates self-reactive lymphocytes, which then produce antibodies to host nuclear antigen. Antigen-antibody complex are generated at low level and taken up by dendritic cell. DNA antigen activates toll-like receptor and amplifying immune response via interferon alpha. Antigen antibody complex are subsequently generated at higher levels and deposited in multiple tissue, causing disease. Deficiency of early complement protein C1, C4, and C2 is associated with systemic lupus erythematosus. Almost any tissue can be involved. Classic findings include fever, weight loss, fatigue, lymphadenopathy, and Raynaud phenomenon. Malar butterfly rash or discoid rash, especially upon exposure to sunlight, oral or nasopharyngeal ulcer, are usually painless. Arthritis usually involve more than two joints. Psoriasis, pleuritis, and pericarditis. Psychosis or seizure. Renal damage include diffusive proliferative glomerulonephritis, the most common and most severe form of injury. Other pattern of injury is membranous glomerulonephritis also occur. Anemia, thrombocytopenia, and leukopenia due to type 2 hypersensitivity reaction. Lehmann Sachs endocarditis. Antinuclear antibodies, sensitive but not specific, and anti-double-stranded DNA or anti-Smith antibodies, highly specific. Antiphospholipid antibody is associated with systemic lupus erythematosus, one-third of patients. Autoantibody direct against proteins bound to phospholipids. Important antiphospholipid antibodies include anticardiolipin, false positive VDRL and RPR syphilis screening tests, anti-beta-2 glycoprotein 1 and lupus anticoagulant, falsely elevated PTT. Antiphospholipid antibody syndrome is characterized by hypercoagulable state due to antiphospholipid antibodies, especially lupus anticoagulant. Result in arterial and venous thrombosis included deep venous, hepatic vein, placental, recurrent pregnancy loss, and cerebral stroke thrombosis. Require lifelong anticoagulation associated with systemic lupus erythematosus. However, more commonly occur as a primary disorder. Antihistamine antibodies characterize of drug-induced lupus. The causes of drug is procainamide, hydralazine, and isoniazid are common causes. Antinuclear antibodies is positive by definition. CNS and renal involvement are rare. Removal of drug usually result in remission. First-line treatment include avoiding exposure to direct sunlight and glucocorticoid for flares. Other immunosuppressive agents are useful in severe or refractory disease. 5-year survival is more than 90%. Renal failure and infection and accelerated coronary sclerosis occur later, common causes of death. And in this picture, we see malar butterfly rash in patient with systemic lupus erythematosus and discoid rash also in patient with CLE. Thank you. The next topic is Sjogren's syndrome.